Alpha-1 antitrypsin deficiency is the most common lethal single-gene defect of Caucasians in the United States. Nearly 100,000 people are believed to carry the severe form of the deficiency, yet only 5% are identified. How can that be? We believe that one reason for this underdiagnosis is that Alpha-1 antitrypsin deficiency, also known as A1AD or Alpha-1, could be called the great pretender.
When do we consider the diagnosis of Alpha-1 antitrypsin deficiency in a clinical practice? And I think the diagnosis should be entertained any time somebody comes with early onset emphysema. Most common garden variety, if you will, cigarette smoking related emphysema occurs in individuals in their certainly late 50s, 60s, even 70s. This is a disease of older ages. But should someone present to your clinical attention with emphysema, with a combination of fixed airflow obstruction, with sophisticated pulmonary function tests that show a decrease in the diffusing capacity, or even with an X-ray, frankly, showing emphysematous changes, hyperinflation, decreased vascularity on the chest X-ray, and quite peculiarly to Alpha-1 antitrypsin deficiency, hyperinflation at the bottom of the lung, at the bases of the lung, as opposed to the apices of the lung, which is where the X-ray is more frequently abnormal in garden variety, non-Alpha-1 deficient related emphysema. Should someone present with that kind of X-ray, early onset emphysema, the diagnosis should certainly be entertained, again with a blood test. Similarly, should someone present with cryptogenic cirrhosis, perhaps with or without lung disease, that may be an indication to suspect Alpha-1 antitrypsin deficiency.
Liver disease, a less common manifestation of A1AD, develops in approximately 10% of those diagnosed with A1AD. Symptoms of liver disease can appear in infants, children, and adults. Symptoms of A1AD liver disease in infancy and children may include prolonged obstructive jaundice, mildly elevated liver enzymes, and symptoms of cholestasis, including jaundice, dark urine, pale stools, and itching. Other symptoms in infancy may include enlarged liver, bleeding diathesis, ascites, feeding difficulties, and poor growth or failure to thrive, and in children, severe liver dysfunction. A1AD liver disease symptoms in adults are any or all of the following: chronic active hepatitis, cryptogenic cirrhosis, portal hypertension, and hepatocellular carcinoma.
Should someone present with paniculitis, that should lead to the suspicion of the disease and lead to testing for it, a blood test for a serum level and perhaps a phenotype.
Paniculitis, a third and rare manifestation of A1AD, presents itself as skin lesions, predominantly on the torso of the body, and are ulcerated sores, accompanied by fever, and are chronic and relapsing.
And should someone present with a family history of emphysema, should a patient with liver disease, for example, also describe a family history of emphysema, often of early onset in first-degree relatives, that should certainly lead to suspicion. So a combination of any of those presenting symptoms should certainly lead to suspicion.
Indications for A1AD screening include premature onset of moderate to severe COPD before the age of 50, predominant basilar emphysema, chronic bronchitis with airflow obstruction in a non-smoker, bronchiectasis without clear risk factors, development of unremitting asthma, especially under the age of 50, family history of Alpha-1 antitrypsin deficiency, cirrhosis of the liver without apparent risk factors, and or a family history of paniculitis.
It's been shown, studies by Dr. Lieberman and his colleagues some years ago, that about 2 to 3% of all patients with emphysema will be found to have emphysema on the basis of severe Alpha-1 antitrypsin deficiency. Nonetheless, if I were presented with an asthmatic who also had some features of emphysema and with a family history of emphysema and perhaps with a family history of liver disease, it would be my view that testing such an individual for Alpha-1 antitrypsin deficiency would be sensible. It's a cheap and and really harmless, no more complicated than a blood test. Why don't we as a medical community make the diagnosis more appropriately? And that's an important question. There are some paradoxes about what we know about this disease. In some ways, it's a paradoxic disease because much more is known about the molecular biology and the genetics than is known about the clinical aspects of the disease. But notwithstanding that, it's an important question why we don't make the diagnosis more often. We ourselves have conducted a study in which we've shown, for example, that the mean number of doctors that patients with alpha-1 antitrypsin deficiency of a severe variety had to see before the diagnosis was made was about 3.5. Some patients seeing up to 10 physicians. And the mean duration between the first onset of lung symptoms attributable to alpha-1 antitrypsin deficiency and the ultimate diagnosis was about 7 years. So it doesn't jump out at you, and the evidence before us is that we as a medical community frequently fail to make this diagnosis, usually because we fail to consider the possibility. Making the diagnosis, fortunately, is very easy. It's a matter of sending a blood test for a serum level, and if it's confusing, to get a so-called phenotype, which is done by isoelectric focusing and looking for the proteins that migrate in an electric field and that characterize the presence or absence of these abnormal alleles. Most commonly the Z allele, but there are, of course, many others, perhaps 75 or 80 or so have been defined to date, and undoubtedly many more exist. So it's a matter of linking the suspicion with, with a simple test, which is inexpensive and not too noxious, except for, a blood test.
This chart shows risk factors in developing the manifestations of A1AD based on measured blood alpha-1 antitrypsin serum levels and phenotypes. The red zone indicates high risk for development of A1AD. The red zone indicates the ZZ phenotype, where serum levels are between 3.4 to 7 micromolars, or 18 to 36 milligrams per deciliter.
The doctors where I worked first noticed a blunting on my lungs in 1981, and I went undiagnosed until 1989. December of 89. So if I could have been, if somebody could have properly read the x-rays from 1981 and noticed the blunting in the lower lobes of my lungs, I could have been diagnosed 8 years prior to when I was.
I was diagnosed very early in life at age 7, and I feel very fortunate that I was diagnosed early because I was steered away from smoking. So I don't have any symptoms of alpha-1 now, and I think that's due to my not smoking.
I found out that all of my family had died of it, and they didn't know. So I feel like a pioneer, sort of, because I'm going to stop the cycle of this huge family.
I had to give up my career in construction, very hard physical work that I just no longer could do, and I couldn't be around it as a supervisor because of the dust and what I would inhale.
I think I've been able to live better with my disease since I have been diagnosed, because at least I know what I'm fighting against. Before, I wasn't real sure.
We hope that by listening to this presentation, you have a greater appreciation for this common genetic disorder. Early detection allows those with alpha-1 time to make informed decisions regarding their careers, lifestyles, and health habits. Healthy choices can improve the quality and quantity of their years. We know that someday a cure will be found. Until that day, we will continue to improve through support, education, and research the quality of life of those affected by alpha-1 antitrypsin deficiency. Help us ensure that those whose lives are forever changed by alpha-1 may feel unique but not alone.
Hope there's a cure. I mean, that's my bottom line. I mean, I hope that someday, whether it be gene replacement or, whatever, I mean, I hope that someday there's a cure for this and that, people don't have to suffer from this disease.